Let me pull my information up here. Okay, good afternoon. Most said morning. Good afternoon and welcome to the Davies Use Case webinar being presented by Lafayette General Health on clinical documentation improvement. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. The use of health IT to improve the quality of healthcare delivery. HIMSS the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT and health delivery. So it's my pleasure to welcome our speakers, Jesse Hanks and Dr. Manilog, to this presentation today. And I will allow you all to introduce yourself as I transition and turn the slides over to you.
To you our journey through clinical documentation improvement and the outcomes we have achieved using streamlined technology. My name is Amanda Logue. I have been with Lafayette General Health for about 8 years as an internal medicine hospitalist, and for the last 5 years additionally as the Chief Medical Information Officer.
I am Jesse Hanks. I am the System Health Information Management Director and Privacy Officer for Lafayette General Health. I've been with the system for 5 years and in the healthcare for 20 years.
Going over a little bit about who we are at Lafayette General Health. We have over 7 inpatient facilities covering a large area of our community, one of which is an academic center. We also have over 40 ambulatory sites, and because we're a large community-owned hospital, we have a significant number of non-employed medical staff. They are an independent medical staff in our community, and they come from rural areas as well. We have over 1,700 community medical staff members throughout our system, and only about 70 of them are employed by us. This presents an interesting challenge whenever we want to push through initiatives. You can also see a bit about our patients and the volume of visits that we do every year. Of growth, both within the organization and through our expanding information systems implementation. 2003, when we started our journey, into 2015, where we highlight the new CDI process that we are presenting on today, and moving into 2017 and 2018, where we have much more to come. Been an exciting topic for physicians. Historically, they didn't really have much concern over how much the documentation was reflected within the hospital, and we struggled with having easy and open lines of communication with physicians, especially when we were seeking additional information about patients and their documentation. Our was also very siloed, and it didn't have timely and accurate integration with the patient's chart. So we had a real opportunity to improve our documentation, our query response rate from physicians, and all the implications that come with that, including not realizing our full reimbursement potential and not coding accurately. You can see that it did show a decent number of queries that were being generated with a fair response rate, but we definitely knew we still had opportunity. Our physician community was really starting to notice that things like our case mix index didn't really reflect what we thought it should. And with the changes in healthcare reimbursement from volume to value and regulation, we really started to shine a spotlight on areas that we were not documenting very well. So even with some decent numbers to start with, we knew that we had opportunities in many ways. So design, implementation, and government. Within we had our executive sponsors was our Director of HIM, our CMIO, and our Chief Medical Officer as well, too. We had multiple teams engaged, our HIM department, the Information Systems department, and, of course, our physicians. Our goals for the project were to create an easier and more efficient coding process to more accurately illness and the risk of mortality based on documentation that was in the chart. As the physician community reflected upon quality metrics and outcomes, some of the topics we began to include with the new CDI process were anemia, CHF, wound debridements, and pressure ulcer documentation. These also became standing topics at our Clinical Transformation Committee meeting. Our CTC is chaired by the CMO of the hospital, and it's made up of physician department chairs and physician service leaders, HIM, quality and outcomes, nursing, and case management. This committee reports to our Medical Executive Committee on quality initiatives, tackling issues of outcomes and documentation, and peer review findings. So the CTC was our main source of physician involvement for this project.
Major events timeline. And back in 2011 is when our program started, and at that time our vendor of choice was Centramed, which was good in reporting, but it was more of a database, and so we were very limited with the tools that we had to be able to execute the queries. In 2014, we utilized our CDI program to start looking at mortalities, and we were very successful with that. Through the wins that we had with that, we were able to bring in a new vendor, Streamline Health, to replace Centramed, which was integrated within Cerner. Before that, we would have to print up the queries, fax them over to the physicians, have them sign them, fax back, and then scan and put them into the chart, which was very tedious and time-consuming. And also in 2015, we acquired a hack, and through that, we decided to utilize our CDI program to also review complications of care and hack accounts. We were able to acquire additional staff through acquisitions over the last couple of years, and also most recently centralized our HIM department, which also centralized our CDI program. Again, adding more staff to the program, which will be managing over all the facilities. And most recently, again, we engaged with a consulting group that came in and did a very intense 6-week boot camp, not only with our CDI specialists, but also our coders. We knew that we wanted to build into Streamline an opportunity to get the biggest bang out of our buck. So we wanted to make sure that we were looking at certain payers. Also, Streamline is interfaced with Millennium for that ADT feed coming in. The technology configuration is launched within Streamline, and it utilizes the same Citrix servers used within our 3M encoder. Our new CDI software, Streamline, was implemented. Based on the coding criteria, CDI specialists submit a query to the providers. The query is interfaced directly from Streamline into Cerner, which is our electronic health record. The providers can update directly from the patient chart and send it back to CDI. Here you can see a very in-the-weeds diagram of our coding query process from beginning to end. And this is very detailed, but you can see that in the green boxes where the IT is being utilized. In that same process, we utilized our CDI program to also look at mortality review. So again, very in-the-weeds diagram of how we utilize the program to review the mortality. And in the green boxes there also are the IT utilization. This is a snippet of what the CDI specialist sees in their box when they're reviewing the queries. At the bottom, you can see that a query that has been answered by a physician and the CDI specialist is reviewing it. At the top of the screen, you can see that they're able to select what CDI impact that it's bringing back in. This is an example of what a query looks like to the physician. You can notice that it has options for the physician to select, and once the physician modifies it, it becomes part of the legal chart, and the CDI specialist gets notification within their bucket that that query has been completed. This is a view of the physician's message center, and you notice on the left-hand side of the red circle, under documents, it notices that there is a document to be signed by the physician. And then in the middle of the page, the next circle shows that it's a coding query. It also lets the physician know who it is from. And then once they click on that line, it opens up the query, allows them to read it, and then at the top bar, it also allows them to modify it and answer it. Once that is done, it is completed. It is now part of the legal chart, and also that CDI specialist is notified. This is an example of what a coder or the CDI specialist would see within the 3M encoder, and it's comparing two different initial documentation and the coding identified opportunities, comparing the first codes versus the initial codes that were brought in from a query. You can notice the two different total amounts that are being brought in, and also the diagnosis is on the right-hand side, an added diagnosis of sepsis. This is what the coding CDI specialists are noticing in their CDI solution. It shows the current coding workflow, and on the right-hand side, it is the working coding workflow, and it's what they're anticipating of getting back from the physician. And you can notice on this one is a malnutrition code that was added. You can notice also at the top the DRGs have changed, the weight has changed, and also the reimbursement has changed just by bringing in that malnutrition. The value of our program is obvious. Here you can see over the past couple of years, the bars are showing the number of queries, and the line graph is showing the query response rate. Over the years, as we've gotten better at our program, our physicians have gotten more comfortable in understanding the why behind what we do, and you can see that their response rate has increased. Fiscal year 14 and 15, you can see there's a huge jump in the numbers there. That is when we implemented our new CDI solution that was integrated into Cerner. Here you can see the increase in the MS-DRG changes. In fiscal year 15, it looks like we did not have an increase, but we really did. As back here on this slide, you can see such a huge increase in the number of DRGs. It's just that the percentage is lower. And dollars. Here you can see the net dollar variance for reimbursement over the last couple of years. And that's for LGMC and for the system. Each year we have a goal of what we want to obtain. This year our goal was $2 million. And when we did this slide, we were projected to hit $2.2 million, and as of today, we're at $2.7 million. So we're very excited of the wins that we've had with our program. Next step, we're looking to expanding the scope of the CDI program to capture key documentation initiatives. We want to complete phase 2 for our go live with Streamline Health, which is our CDI solution, which is expected to happen this month. We have new multi-facility dashboards that we're really excited about, and also the upgrading in the reporting system so that we're able to communicate to all the administrators of our facilities the wins that we're having with this program. Continued engagement with consulting group for ongoing education and process improvement. We've identified 4 CDI physician champions for LGH, and they will act as liaisons at each one of our facilities and between the physicians and also our CDI program. And rolling out additional physician education along with a big CDI day at each facility. We hope that you've enjoyed our presentation on clinical documentation improvement. We're excited that we were able to share this journey and our success story with you. Thank you for listening.
Well, thank you for that great presentation. And thank you for joining us for the Davies webinar, more Davies use cases webinars. For Davies use case webinars and information on how to apply for the Davies Award can be found at hosted at the HIMSS Davies Award website, hims.org/Davies. Thank you all again for your presentation, and I think we have one more to do.